Hello. I hope that everybody can hear us here. I'm not sure how many people we actually have already on the webinar, but we'd like to start on time tonight so that we can get through our very interesting and slightly long program on time and leave plenty of time for questions. I first of all would like to mention the paediatricians that are here and dermatologists from Sunshine Coast University Hospital that you can see on the screen that have kindly given up their time to be here with us this evening. And that, you know, previously we've had sessions that have been at Sunshine Coast University Hospital that have been really popular and well attended. But I think that tonight's session, even though it's a different format, is really relevant to general practice, and I hope that everybody finds it useful. I'll just flick to the next slide because I'd like to do the acknowledgement to country. So the PHN and the Sunshine Coast Hospital and Health Service acknowledge the traditional owners of the land on which we meet and pay respects to our elders, past, present and emerging. Thank you, Jodie. I'm Dr. Michelle Johnston, one of the GP liaison officers from the Sunshine Coast Hospital and Health Service. I think most of you would know me. I'm just going to be, I guess, emceeing the night tonight and trying to keep us all on track so that we do have that time for questions at the end. If you do think of anything, have any questions, just pop it into your chat box. We won't take them as they come in. We'll cover Leith's questions after her session, and then the rest of them will be at the end of the night. So but you can put them into that chat box as we go. Before we do that, I'd just like to, or before we move on to Leith's presentation, I'd like to take 1 minute to advertise our GP with special interest program that we have at the hospital, because we're currently recruiting again for gynecology, rheumatology, gastro, vascular and general surgery. It's a great opportunity for GPs to increase their skills in these areas, and also to give their general practice skills to the hospital and help to build those bridges and build that, I guess, yeah, build the understanding between general practice and the hospital system as well. So if you are interested, just pop a message into the chat box through the night and we'll try and get back to you. And now I will end there so that we have enough time for Leith, and hand over to Dr. Leith Banney, who is our Director of Dermatology at Sunshine Coast University Hospital.
Thanks, Michelle. Good evening, everyone. My name's Leith Banney. I work at SCUH. We do a paediatric dermatology clinic every second Monday morning, and I work in association with Deb Verkulen, who couldn't be here tonight. She's off camping, having some well-deserved fun, and our two registrars, and it's a really great clinic to be a part of. The patients are very appreciative. A large number of those patients have eczema, and we're just about to be given a new treatment in our armamentarium for these patients with really severe eczema that we struggle with. So everyone was very nervous about my talk. I had a lot of slides, so what I've decided to do in the interest of time is knock off the first third, and we're just going to start with talking about dupilumab. So dupilumab is the first biologic treatment for atopic dermatitis, and it will be listed, I'm told, by the drug company before Christmas this year. Any moment now, it'll be PBS listed. It's already got TGA approval for use both in atopic dermatitis 12 years and older, and also as an adjunctive treatment for asthma in 12 years and older. I think we're really now where we were with psoriasis 10 years ago. So the last 10, 12 years, we've had all of these new, fantastic, really effective treatments for psoriasis, which have really changed people's lives. And now that's about to happen in eczema. So the first cab off the rank is dupilumab. Unlike the early psoriasis biologics, this is a really safe drug. It's a really exciting drug. The only screening test we're told we need to do is to check for strongyloides, because its mode of action is the same as what we would use evolutionarily for killing parasites and intestinal worms. So the only screening test we do is strongyloides serology. I'd also do basic full blood UNE-LFT, and we also have to do our eczema scoring, so our EASY score, our quality of life and physician's global assessment. So I'm going to get really good at doing lots of scoring tools. But no blood monitoring is needed. It's a fortnightly subcutaneous injection. And the main side effect we come across is conjunctivitis. So it works by blocking interleukin 4 and interleukin 13. So we can go to the next slide. There we go. So how good is it? So I guess from this slide, which is one of the biggest studies, at 4 months, about 75% of people are 75% better. So that's really, you know, revolutionary. That's better for most people than cyclosporin. And the side effect profile is so much better than cyclosporin, azathioprine, methotrexate, mycophenolate, all of those other drugs that we would normally use for severe atopic dermatitis. So it's working on that Th2 cytokine milieu, which is the interleukin 4, 5, 12, 13 in acute eczema. Next slide, please. So this is a breakdown of side effects we see, and you might think, well, how bad could conjunctivitis be? But it turns out that it can be, you know, really, really difficult to tolerate for some of these patients because they've already got pre-existing atopic conjunctivitis. So we have already made up a information sheet for people managing their conjunctivitis if they're starting on this drug. There is a slightly increased risk of oral herpes, and some people develop more of an eosinophilia. Next slide, please. So the indications, as I've said, is for atopic dermatitis in people who meet those severity scores, 12 years and older, which still leaves our little kids without access to this medication, but I can foresee that maybe we'll be trying to provide it on compassionate grounds for some children, as well as for asthma. Next slide, please. It is available via private prescription, but as you can see, it's $1,600 a month. So for the vast majority of people, that's just not going to be accessible. But there will be some people who will be able to access it privately. Next slide, please. As I've said, there's very little in the way of contraindications. We wouldn't use it in people who are pregnant or breastfeeding because we don't have evidence. We don't know what it does to your immune response to a vaccine or a live vaccine, so that would be out of the question as well. Next slide, please. And no laboratory monitoring is needed, which is just wonderful, particularly when you're talking about teenagers and those 12-year-olds and over using the medication. Next slide, please. And this, as I said, is going to be the start of better eczema treatment. And the other things that are in the pipeline, when you have a look at the literature, are the JAK inhibitors. And we already have a patient on tofacitinib because she's obtaining it through the rheumatoid arthritis pathway. She's doing very well on tofacitinib. Some of our psoriasis drugs are also being trialled because although the acute phase of eczema has that interleukin 4, 13, 12, 5 eosinophilia cytokine milieu. In chronic eczema, where we get the lichenified thickened skin and it's been going on for years, we start to get the interleukin 17 and interleukin 22 and more of a Th1 profile evolving as well, so that these drugs do seem to work as well. So secukinumab, I think, is in has had some effective trials. Stelara has also been shown to be better than placebo, but not significantly better than placebo, unfortunately. And really interesting to me is nemolizumab because this blocks interleukin 31 receptor. Interleukin 31 is released by T cells and eosinophils, macrophages, and it actually has a direct action on peripheral nerves like a nerve growth factor. So it causes growth of nerves and increased sensitivity of nerves, and it's a really important part of that itch scratch cycle. And if we can block this, it's going to relieve that constant itch, which is just so debilitating for atopic dermatitis patients. And I'm also hoping that we'll be able to use it in some of our prurigo nodularis patients and patients where the cause of the itch is uncertain, maybe even our renal failure and liver failure patients, we're not sure yet, but it's a specific cytokine interleukin 31 that's right there in the center of the creation of itch, and I think that's going to be a very useful drug. And vezakinumab is another interleukin 22 blocker that's now in phase 2 trials. Next slide, please. And I'm sure you've all heard of this atopic march, meaning that we need to keep the skin good in young children and infants so that they're not exposed to allergens through the cutaneous route, and they're exposed to the allergen through the normal route that the immune system should come into contact with that allergen. And so exposure of a food allergen via gut produces tolerance, whereas exposure of a food allergen through the skin can cause allergy. So then we progress after the eczema to food allergy and onwards to allergic rhinitis and asthma. It's not always, of course, that stepwise progression in everyone, but this is the importance of keeping the skin good, or one of the important factors, apart from the terrible lack of quality of life with severe atopic dermatitis. Next slide, please. I should probably also, before we leave dupilumab, say that we've had 6 patients on dupilumab so far. 5 of them have done beautifully and find it life-changing, and it's just so rewarding to have a patient say it's changed their life. The one patient who is kind of our poster boy for success with dupilumab is a man in his 20s who was an insulin-dependent diabetic because he was taking courses of prednisone quite frequently to control his dermatitis and ended up with insulin-dependent diabetes. On dupilumab, he's been able to stop his insulin. So for that particular individual, this literally is going to add years to his life, and his whole quality of life has improved. But for all of the others, it's worked as well. One person though, the lady who I talked about already on tofacitinib, couldn't tolerate dupilumab because of conjunctivitis. So it really can be a problem for people. This is a little slide about where we go with allergic testing. So when the parents come in and say to us, what is my child allergic to? What's the cause of this dermatitis? And of course that then starts a discussion about the fact that there's not going to be one particular thing causing an allergic reaction, and that this is a complex interplay of a genetic predisposition, environmental exposures, and that if you have severe atopic dermatitis, you'll overreact to lots of things and lots of foods in your environment. And so that for patients in this particular study, so this was a Melbourne dermatologist back in 2006 who put together a study of his own patients and what they reacted to on skin prick testing, and he found that 2/3 of the infants with moderate or severe eczema will have positive IgE, RAST or prick testing to multiple foods, but removing this food isn't going to be a curative process. Having said that, we might find an exacerbating factor. So that's what allergy testing is all about, and I think it's important that the patient and their parents understand it's not going to be a curative process, but we may well find exacerbating factors. As you probably know, milk, egg and wheat usually resolve as the child grows older, but nuts and fish allergies don't. And some unfortunate individuals also have an IgE positivity to staph and to Malassezia, previously called Pityrosporum. So that's the yeast we all have on our skin. So if you see somebody who has very severe head and neck dermatitis out of keeping with the rest of their body, so the rest of their body is mild, you might consider whether they might have a Malassezia allergy, and a course of oral antifungals such as a fluconazole or itraconazole may be worthwhile, and some of these people will improve with that treatment. There is also a little bit of evidence when I was reading for this talk that keratinocytes can act as self-antigens in atopic dermatitis, and you get an IgE reaction to some of your own surface markers on your keratinocytes, which, yeah, that's a whole nother story. Next slide, please. So, summarising that allergy testing, we can find exacerbating factors for atopic dermatitis. We don't do it for kids with mild atopic dermatitis because we know they're almost certain to grow out of their dermatitis. They're always going to have a sensitive skin, and this should be taken into account with their career path and choices in life as to what they're going to work at for a career. But for the moderate or severe kids, we do food allergy testing. We know that positive RAS tests are not always relevant, and the degree of positivity can change over time. A very high test is much more likely to be relevant clinically than a low or borderline test. 90% of positive reactions will be to those 5 common allergens. So if we're not sure where to start, we would just start with those 5 common allergens. Most kids with severe or moderate atopic dermatitis are house dust mite allergic, and very often severely so. So testing to that, although it can be helpful, but really you can take it as a given that they usually will be house dust mite allergic. And you can do more allergens with prick testing, and I was talking to James Scorer, who's speaking to you next, and he does that in his private practice, and several GPs do as well. So prick testing is available on Sunshine Coast as well. Next slide. And dysbiosis. Now this is, as you know, just an evolving story in nearly every area of medicine, particularly with the gut microbiome, but also the skin microbiome. We know that in atopic dermatitis, there's a greatly increased number of Staph aureus as well as Corynebacterium. Staph is particularly a problem because it can act as a superantigen, activating T cells and B cells very rapidly. It releases proteases and toxins that act back into the immune system and really drive that inflammation. So Staph eradication can be really helpful in control of dermatitis. We talked already about Malassezia hypersensitivity. The gut is an evolving story. I'm just going to say that we know there's less bifidobacterium and more Staph aureus in the atopic gut, but that will vary from individual to individual, and we're all probably going to be able to come up with our own profile for our microbiome and what we could do to improve it with respect to the various pathologies we all develop. So lastly, with dysbiosis, that Th2 skewed cytokine milieu does inhibit the production of little molecules called antimicrobial peptides. So keratinocytes produce things like cathelicidins and defensins, which fight off bacteria in the skin. And without that ability to fight those things off, there's increased skin infections that we see in atopic dermatitis. Next slide, please. This is page 1 of an eczema management tool that one of our wonderful interns, Hannah Gribben from last year, has put together. She's more recently done a term in paediatrics, and one of the paediatricians she was discussing with said that there was not a protocol in place for how eczema could be managed on the ward uniformly. So she's spent a bit of time making this really excellent and brief management sheet. So it's got a very simple severity assessment tool at the top, just taking into account erythema, excoriation and edema papulation. You come out with a score, mild, moderate, severe, and then you can stepwise follow the pathway of what creams you should be using. Then there's a table at the bottom of how many fingertip units you should be using to treat. Can I have the next slide, please? And over the page, she's got tips about wet wraps, cool bathing, how much emollient you should be using just as a guideline, because we know a lot of people underuse their creams, and a little bit about education. So our aim with this, and we need to work, we're going to come back to the paediatricians about this, but our aim would be to produce an assessment tool that could then give a pathway to appropriate treatment, and that an eczema management plan could be put into the electronic medical record, and a copy of that would go back to you as caring GP, and so we'd all be on the same page and we'd all be saying the same thing for that particular patient, which I think would be very valuable. Next slide. And if you wanted to do this kind of thing in your practice, I would refer you to the SCUH website, which is excellent, has lots of information about eczema and other allergic conditions, and this form can be just printed off and filled in with your management plan for that particular patient. And I think it's always good to write it down so that they don't get it wrong. Next slide, please. And I just thought I'd finish with this little child who was misdiagnosed as eczema. So this is a little boy who came into the ward about 18 months ago with 2 weeks of a rash, which was diagnosed as atypical eczema, but wasn't responding to potent topical steroids and oral antibiotics. The parents told us he'd had a fever at home, but actually he was afebrile and completely well during his hospital admission. His full blood count, liver and kidneys were all normal, but he just had this tender, uncomfortable, desquamative rash. Next slide, please. And I knew I'd seen this before somewhere at a lecture, and this is a condition called parakeratosis granulosa. And this is an irritant reaction to benzalkonium chloride, which most often comes into contact with the kids via various laundry rinses, so Canestin or Dettol. And you can see from the distribution of the rash that it's completely symmetrical And so that always twigs in your mind that this could be an external, an outside job, so to speak, rather than an inside job. And those areas are the areas where the clothing is most in contact with the skin. So you can see the belly is spared on the front of that child. Can we have the next slide, please? And those are the products that contain benzalkonium chloride. So it's QV flare-up as well, and oilatum plus as well. It's increasing because I think we're getting, people are using these products in their laundry more. The information sheets or the textbooks say that this condition should resolve really quickly, but I think sometimes it's in all of the clothes and it takes quite a few washes to get it out of the clothes and the sheets. So the couple of cases we've had have actually taken more than a month to really settle properly. And an elderly lady we had recently, it went on for about 2 months, and it was really debilitating for her because she wasn't in you know, good health to start with. But I just thought that was a good one to bring to your attention. I'm not sure how I'm going for time, but I'm sure Michelle will tell me if I have time to go back and do the rest of my talk, or whether I'll be quiet for now.
You can probably, we haven't actually got any questions that have come up. Somebody asked for a slide to be repeated, but we're going to, they're all attached and we can show it at the end if there's time, but they are all attached here for people to look at. So I think you've got about 4 minutes, Leith. If you want to jump back to the first couple, that's up to you. I can't see any other questions at this stage.
Okay. So the initial part of my talk is really about talking to parents about steroid use and their concerns, because I'm sure you're all aware there's a lot of steroid phobia and even this thing on social media called steroid addiction, which isn't really a thing. So one of the main reasons we see kids with eczema is that the parents aren't using the treatment as prescribed. And we know that the impact of atopic dermatitis is really severe. It's actually been assessed to be worse than having a child with type 1 diabetes for all of those reasons listed there: sleep deprivation, cost of the care. Next slide, please. So the things that parents say: I don't want to use steroid creams on my child. I don't like to feel greasy. The creams sting. I'm allergic to everything and I want to find out what they're allergic to. Some of those things we've already answered, but I think it's useful to just sit down and say we don't have a cure for this condition. We don't have gene therapy available to us, but that we know steroid creams are blocking the inflammation and they are effective and safe for continued use when used appropriately. I don't think people who say they don't like to feel greasy have tried enough things. Nobody should have to feel greasy because we have gels and lotions and creams rather than necessarily having to use heavy ointments. And I think we need a range of topical products. Obviously in winter we need greasier, heavier things, and for the lower part of the body, which is drier, we use those things as well. But for the face and for summer, we don't want to use something that's so greasy that we begin to feel hot and sweat and itch more. So having that discussion with the patient, they realise, oh, I should maybe not use the same heavy one in winter on my face in summer. It's just a discussion. Sometimes when the skin's broken, everything stings, and sometimes when it's infected, everything stings. And a useful thing can be to use either Dermies or white soft paraffin or Vaseline over the worst breaks and then ease the child into a lukewarm bath. You just have to start applying the creams and work through that initial discomfort. And there's tricks for that with adding food dye so the child can choose what colour bath water they want, adding all the goodies like the oil, the salts to make a neutral pH, and bleach baths if you're going to use them. And the Royal Children's Hospital in Melbourne has a really good lot of instructions for how to do all those things. And we've talked about the allergy testing already. Next slide, please. The pharmacists frighten the kids too with this use sparingly, and I think it's really important to give them enough on a script. So to use those streamline numbers and give them a large amount of cream, because if you just give them one tube, I think you're reinforcing that idea that this is a really potent, scary thing that they're putting on their skin. So I like to give them liberal quantities of appropriate strength steroid, and there's a consensus statement on our Dermatology College website that I can give Michelle the link to, that goes through the evidence behind all these steroid-related concerns. And you can print that out for people who have concerns and just explain that most of these things are not based in fact. So there's no evidence that thinning of the skin occurs when steroids are ceased with appropriate treatment. So I usually say keep going until it's gone, and then a day or two after. As far as long-term management, you might like to prophylactically use something, and I love tacrolimus in this situation. If you've got stubborn areas around wrists and ankles, to use that a couple of times a week. We know we're not going to get skin thinning using that semi-regularly to try and stop any flare-ups. Hypopigmentation is due to the eczema. It's not due to the steroid. It's post-inflammatory. And there's no need to worry about putting steroid on eroded skin. I've had lots of people come in with eroded skin saying, oh, I can't use the steroid cream because the skin's broken and I'm worried about that. Next slide, please. And we know that putting more steroid cream on doesn't necessarily increase the amount that you absorb. There are binding sites in the dermis, and when that reservoir of binding is full, then you won't get increased absorption. So putting it on more times a day doesn't help, and diluting it with an emollient doesn't stop you absorbing it. You're going to absorb the amount that you're going to absorb. Next slide, please. And I think I'll skip that slide, please. This, I think, might be a little bit of a mini epidemic because the chemists are now allowed to hand out Elicon over the counter. And Elicon, in my humble opinion, is probably the worst cause of perioral or periorificial, because it can occur around the eyes as well, dermatitis. So there'll be people using this cream that shouldn't be using it on their face, and we're going to see probably more perioral dermatitis. Next slide. This goes back to that consensus statement, and as I said, I'll send Michelle the link to the consensus statement about the use of topical steroids. Next slide, please.
And we'll have to wrap up as well, Leith.
Good idea.
Do you think it's a good moment to, the rest of these slides are on there, and nobody's actually sent any questions through. So I know you've got a few slides left, but we might have to leave it at that point.
Thanks, Michelle.
Okay,
yeah.
Great. Thank you very much, Leith. We will move on. If you think of other questions, just through the next few talkers or speakers, put them on there and we'll come to them at the end. So now we're going to hand over to Dr. James Scorer, who's one of our local paediatricians, to talk about allergic rhinitis. Thank you, James.
Just want to make sure that you can hear me. I can't see. People can see your screen. Okay. So we're ready to roll, are we?
We are.
Everybody? Okay. So hang on. People can see my screen, but I can't. Huh. Okay. There we go.
Okay, that's all right.
I can't. I can see.
We can see you, James.
But I can't see my screen.
Okay.
Everybody else can.
Does Jodie have your slides there?
She does, but I don't. I saw them just now. Hang on. I don't want to. There we go.
While James, yeah.
There we go. Can everybody see that?
Yes.
Oh gosh, now it's disappeared.
That's okay. People can think about questions.
Okay, that's fine. So I've been asked to talk about allergic rhinitis in children. I've got quite a lot of slides, so hold your hats, blow your nose, and put your mask on, and we'll go for it. Allergic rhinitis is really common, and the census data says that about 15% of people in Australia have got allergic rhinitis, but it's really underdiagnosed and underrecognized by parents, and usually suboptimally treated. Often they're using all sorts of complementary products which aren't really going to help, and often the allergic rhinitis is considered a nuisance with no effective treatment, so the poor children have to put up with it. It has significant health and quality of life effects, and treatment is chronic, and a bit like treating eczema or diabetes, it's dogged by compliance issues. The prevalence is, most data is from adults. 42% of adults have mild to severe allergic rhinitis in Australia, 37% in New Zealand, and so on, less in Europe. And local estimates are 30 to 50% of children aged 6 to 18 have nasal allergy of varying degree. That's from Connie Catalaris at the University of Western Sydney. The symptoms, I think we all know: nasal congestion, obstruction, mouth breathing, snoring, itchy throat and throat clearing, itchy nose, nasal speech, and all of these lead to major problems. The main symptoms in a study done by Professor Catalaris is that nasal congestion seems to be the most prominent concern, and sneezing, runny nose, nasal itching. That's again the same one. I didn't take that one out. I think the important thing here is that this isn't something that should be, apologize for the pun, sneezed at. It affects work performance, school performance, up to 20% of absenteeism, and 30% of children said that it interfered with their schooling, that they felt tired, and they in the day, and another 40% felt tired during the day sometimes. 30% felt sad or depressed, and a lot of the time, and 60% sometimes. Sleep disturbance is a major problem, and a lot of parents don't even realize that the children's sleep is being disturbed. When you ask parents, does your child snore, does your child sleep with their mouth open, and they'll say, I have no idea. When I put them to bed, I leave them there, and I'm happy that they stay there. So sleep disturbance, up to 88% are affected. School performance in the US, 2 million school days are lost every year. And then there's the issue of malocclusion. Mouth breathing often leads to problems with the teeth and with the shape of the mouth. And there's an extra cost because they have to go and visit the orthodontist. So they have more trouble falling asleep. They have more nighttime wakenings. They feel tired in the morning, and they often wake in the morning with bad breath, dry mouth, and then malocclusion. I'm glad I'm talking to GPs here, because GPs seem to make the most diagnoses of allergic rhinitis. But the nose problem may not be the main reason for presenting at the doctor. In my practice, the commonest reason for coming is school learning problems, attention issues. And I'm finding at the moment, the latest tally, probably about 40 to 50% of the children have had nasal problems, allergic rhinitis. So one has to ask those questions, even though it isn't the problem the child came for. So we usually divide symptoms into intermittent and persistent, which helps us decide what sort of allergens may be involved. The persistent children are the ones that I see mainly, and these are the children who have house dust mite allergy. Pollens in children under the age of 12 are rarely a problem. And yeah, with the definitions there, less than 4 days a week or less than 4 weeks makes it intermittent, and usually pollen related. Persistent, more than 4 days a week and for more than 4 weeks, and that leads to problems with sleep. The intermittent ones usually have normal sleep. Then other things one needs to ask about is any particular triggers. In other words, is it particular when a particular pet's around, or and then what medications they're using, and then obviously allergic rhinitis and eczema and asthma rather are best friends, and we obviously need to ask about that. This is just a quick picture to show you what a normal nose looks like. Part of your examination should always be, you look in the ears and you look down the throat to look for tonsils, but the number of people who actually look in the nose, I think is probably not many, and that's what a good looking allergic turbinate looks like. The polyps is a different thing, and I'm not going to go there. These are the things you can see when the child walks in the room. So you can usually spot a kid with allergic rhinitis as they walk in. The allergic shiners the nasal facies, the allergic salute, and often they'll wriggle their noses and sniff when you start talking about their noses. So the signs of allergic rhinitis when you have a look, and there's no need to do rhinoscopy, you can usually see things fairly clearly in kids. They don't have very hairy noses, so it's easy to see that inferior turbinate quite easily. So that the turbinates are usually pale, swollen, have lots of strands of mucus, a clear watery discharge, and sometimes you can see a polyp. And as I say, I'm not going to go there. Things to look out for, that it's making sure that it's not something more serious. If the child's breathing through one nostril, and you can do that quite easily, check that quite easily by putting your mobile phone under their nose and asking them to breathe onto the thing, and then you can see whether or not one nostril is breathing more than the other. If there's blood, pus, a discharge, then you should look for something more. Again, if the allergy tests are negative and if they don't respond to treatment. So asthma is obviously something which we are very concerned about, because allergic rhinitis and asthma often coexist. 80% of patients with asthma have allergic rhinitis, and allergic rhinitis patients have a threefold chance of developing asthma over other children. The other thing is that if you can effectively treat the allergic rhinitis, you can reduce the ED visits for asthma by 50%. This has been shown in good studies. Oral allergy syndrome is an interesting situation. So where there's cross-reaction with certain fruits and vegetables, then when they eat other vegetables or plants from the same group, the children develop an itchy feeling in the base of the mouth. One should always be aware of non-allergic rhinitis, and non-allergic rhinitis can exist with allergic rhinitis, and that's just a few things about non-allergic rhinitis. I'm not going to go into any more detail about that. So as I've discussed already, perennial allergic rhinitis is usually caused by house dust mites, animal dandruff, molds, and it's usually indoor. Seasonal is usually grass, weeds, and trees, and then occupational. And the pathogenesis is where the allergen is, it produces a Th2 response, and then IgE gets onto the mast cells, and then if they meet that allergen again, now it's all quite complex, but that's putting it simply. So allergy testing is obviously part of working out how best to help these kids, but pharmacotherapy can be started before you've actually just delineated what the child is allergic to. It helps you if you do get skin prick testing or serum-specific IgE testing, which is positive, then it tells you, yeah, this is IgE mediated, and that then means that there is a possibility of trying to help them, for instance, with immunotherapy. So treatment involves avoidance. So house dust mites, I'm sure everybody knows, washing the bedclothes, putting mattress covers, and so on. I'll give you a handout that I use for most of my kids. Unfortunately, the compliance with avoidance for house dust mites is not very good. Even when you pay for the mattress covers and so on, probably only 20% of people will actually use them. Interestingly, in the SCUH information about allergic rhinitis, they say that Australian and New Zealand natives are not allergenic. I found some which are, but yes, when there's a lot of high pollen loads, stay inside. Maybe an N95 mask might be quite handy to try and stop things. Hang on. Okay, I'll leave it there. So first line of treatment is now for most children is to use intranasal corticosteroid sprays. That's for the persistent and mild, and that seems to be the first line of treatment. Oral or non-sedating intranasal antihistamines can also be used, but aren't as effective as I'll show you later. Nasal saline irrigation is probably better for the seasonal, because you can wash out all the pollen, allergen avoidance, which we've discussed about, and then for the really severe ones, allergen immunotherapy. There are other, I'll just go on a little bit further. There's one thing I just want to mention, and I've seen a fair number of kids who've been prescribed polaramine and Phenergan for their allergies. They don't work very well. There's a danger that you might have problems with dry mucous membranes, blurred vision, and so on. And it's very sedating. In a composite learning score, looking at kids who are using Phenergan for their nasal allergy, the learning score was significantly reduced in kids who have been put on Phenergan, apart from the fact that it tends to make them a bit hyperactive as well in some kids. So just a few principles. You can start it early. You should need to give it for at least 4 weeks. Intranasal corticosteroids are the first line of therapy for long-term use. It reduces sneezing and itchy noses. It reduces nasal congestion and the itchy, watery eyes. Sometimes you may get nasal irritation and epistaxis. This is usually because the devices aren't being used properly. They don't cause atrophy, and they have minimal potential for systemic absorption, the same as steroids in eczema and in asthma. Just quick thing, administration. It's the pharmacists are supposed to tell the patients how to use it when they buy it, but my experience is that they very rarely do. So the X technique, tilt the head forward, right in the hand for the left nostril and vice versa, and aim for the ear, is putting it simply. Non-sedating antihistamines, they intranasal act very rapidly, and it's combined with fluticasone in dimester. That means that the kid who wakes up in the morning with a full face, can't breathe, nasal speech, you can use AZEP or with that or some dimester, and you get it, but it only lasts about 1 to 2 hours, and you'll get immediate relief from the itchy, watery eyes, sneezing, and so on. Just out of interest, loratadine, claritine, and Aerius seem to be more potent than cetirizine. They're safe and can be used at higher doses than quoted on the box. So you can up dose and down dose according to the symptoms, and you can use up to 2, or some people have even used up to 3 times the dose. They seem to be extremely safe. Other products, Montelukast isn't very good for relieving the symptoms. It does give some relief if the child's using it for asthma. Ipratropium is more for non-IgE mediated rhinitis. It presents the runny nose but doesn't help with the nasal congestion and edema of the turbinates. Saline lavage clears mucus and allergens. Decongestants should only be used very short term to give immediate relief. I know that Adam Blond uses it just so he can get rid of the swelling, so he can actually get into the back of the nose. But yeah, the danger of a rhinitis medicamentosa. Like with eczema and with food allergies, a treatment plan is very useful. This one's good. It shows people how to use the sprays. Some kids have really blocked noses, do need some ENT surgery. They need turbinate stripping, adenoidectomy, more expense, but at least you get temporary improvement in their quality of life, and it halts the long-term sequelae of nasal phases, malocclusion, and dental decay. What the ENT guys often don't do is tell them that they still have nasal allergy and they'll still need the standard treatment.
James, could I just jump in to say we're getting a little bit short on time? So okay. keep going, but yeah, just a time warning.
All right then, thank you. There are lots of scores, and one can use these to decide whether or not you want to monitor how you're doing. I just want to make it just one or two shout outs about immunotherapy. Immunotherapy is where you use commercially available extracts to promote clinical tolerance, and it reduces the frequency and severity of symptoms. It's usually for 3 to 5 years, and basically it does work. It may reduce the risk of new sensitization. It may reduce the risk of progression from allergic rhinitis to asthma, and it may also reduce asthma exacerbations. So I'm just going to leave that one. There are basically two types of immunotherapy: the subcutaneous immunotherapy, which is administered by a subcutaneous, subcutaneously in the back of the arm, and then the sublingual immunotherapy. Sublingual immunotherapy is safer. The kids don't like it. It gives an itchy floor of the mouth. The kids find it hard to keep the product pulled under their tongue for a whole minute. Usually it gets forgotten, and studies in America have shown that by the end of the second year, only 10% of people are still buying the product. But on the face of it, it looks nicer for the kids. I found, however, that subcutaneous immunotherapy works better. Compliance is better. It's only once a month to come and see the doctor, and you get a faster onset of benefit. I just stole this. This is a product handout thing, and the one I want you to see here is usually with subcutaneous immunotherapy, you have an updosing phase, which is usually quite long, 13 weeks. And then if you do it in the cluster, this is for a native allergen. There are a lot more side effects, problems with asthma. With subcutaneous immunotherapy, you probably shouldn't give it to somebody who's got an FEV1 of less than 70%. But if we look at this one, the Allergoid, which is available from lots of different companies, it's literally 2 injections on the first occasion with 30 minutes apart, and after that it's just 1 injection a month. It's really safe, and it's also cheap. So if you think of how much people have to spend on their Zyrtec and their Claritine and their nasal steroids, if you buy Omnaris, you're talking about $60 a shot. Nasonex Allergy is okay, $15, but strictly speaking, it should be script under 12. And this then pays for itself. If we look at the cost, antihistamines might be between $20 to $30 a month. Nasal steroids, $20 to $30 a month. And then something like Dymista would be even more. Sublingual immunotherapy is really expensive, between $80 and $120 a month. So yeah, whereas the subcutaneous immunotherapy is about $40. Treatment efficacy, symptom reduction, avoidance 100%, symptom reduction, that makes sense. Or antihistamines on their own, maybe 10% symptom reduction, whereas with immunotherapy, we can get up to 50%. So allergic rhinitis is common. Parents are often not aware that their kids have their problem, and they rarely come to doctors with this issue as being, this specific issue. It's a chronic condition. Compliance is a problem, and you have to really motivate the parents to treat it. And I just wanted to put a shout out here. We talked about eczema and food allergies, and I just wanted to the Smart Start allergy program. A lot of GPs, especially down in Victoria, have a Smart Vax program where they can remind patients on text message about your vaccination is due. There's an add-on which is asking parents, have you given your children these foods yet? And apparently it improves compliance with taking different foods. If you want to learn a bit more, then the e-training programs, not only for allergic rhinitis, but also for immunotherapy, is available. And that's the end of me. I'd also just like to say that I learned all I knew about allergy from the University of Western Sydney Diploma in Clinical Allergy course. It's amazingly good. It's worth doing, and if you want to add an extra feather to your cap and be able to treat kids with allergy with confidence, then I would really recommend it. They do have a master's degree now, and yeah, so I think that was something which certainly we had the majority of the people on the course were GPs, and go for it.
Thank you, James. That's fantastic. Really helpful and useful talk. We will keep moving because we've got a big program. So the next speaker is Dr. Sara Lucas, who's a paediatrician, a local paediatrician, and we'll listen to her for the next 15 or 20 minutes on wheezing in preschoolers. So
Hi,
hopefully,
everyone.
good.
You can hear me? Yes, good. Hopefully there's some of my mates out there, or otherwise some of the lovely GPs that I've been in contact with about patients. It's nice to see you all, even though none of you, I can't hear what you're saying. We're just going to have a quick chat about Weasley Wheezers. There's a bit of updates, but it's still a bit of a funny topic. Next slide, please. So today I'm going to talk about asthma, although Tom's doing that, so I'm going to leave it largely alone. Preschooler wheeze, the new statewide guidelines that are out, and discuss the management with some cases. Next slide. Look, Jackson is a made-up case, but I thought it was a useful illustration of what we see a lot in our practice, and I'm sure you see a lot more Jacksons than I do. He's a 3-year-old boy. He's Jackson with an X. He's got cough, maybe a bit of wheeze. He's got a bit of work breathing, and we're going to talk about what to do. Now, I am not going to think that you guys know nothing, but what I find really helpful is just to remember everything and to do it thoroughly. And when I listen and have a teaching topic, so I've gone back to the basics. And next slide. So the wheeze differential. Oh, there's an extra G there that wasn't there in my slides. There's a lot of things that can cause wheeze in this age group. Bronchiolitis is I guess a common in the younger groups. Wheeze of infancy, and certainly as I've done my training and been around, reactive airways was what we used to call it in the 90s and 2000s. It's still around, but it's sort of just a descriptor. Wheeze of infancy is equally just a descriptor. Is it asthma? Is it an atypical lower respiratory tract infection, or is it a type of pneumonia? Next slide, please. There is a broader differential to think of, and especially in the toddler group, an inhaled foreign body is something that we need to consider. Cardiac failure, depending on how old the child is, but it can be wheezy. So always listening to the heart, feeling for the pulses. DKA can present with the appearance of wheeze in these acidotic children who are tachypneic and trying to blow off their acidosis. Certainly children with other suppurative lung diseases, cystic fibrosis, bronchiectasis, they can present with wheeze, and all of the anatomical abnormalities that you can otherwise get, tracheomalacia, bronchomalacia, tracheolaryngomalacia, all of those ones. Next slide, please. Quickly just pinging on bronchiolitis, which in Australia is the diagnosis of the under 1-year-old who is wheezy and maybe crackly, which is a diagnosis most associated with RSV and human metapneumovirus, but I'm sure there's a few other viruses out there that cause it. It lasts 7 to 10 days, and we treat it if supportively with oxygen, nasogastric feeds. We've got a high flow if they need it, and that's the stage they need a bit of help is the stage to send them into hospital. Next slide, please. The atypical lower respiratory tract infection is an important one to have in there because they're very often wheezy. I'm talking mainly mycoplasma. And these kids, when you've listened to millions of wheezy chests, I don't think I've really had millions, but I've heard a lot. And it's a very musical sounding chest. There might also be some crackles. These children can be febrile, but not always. They usually haven't had wheezy illnesses before. It is sometimes hard to tell the absolute diagnosis. Sometimes we get the mycoplasma serology or the mycoplasma ping back on an MPA or other viral serologies back. Sometimes we don't. You treat them really as they need. They do respond to a bit of salbutamol, oxygen as they need it, and roxithromycin. And the purpose of my talk today is really not to talk about the efficacy of Rulide, but it is certainly there as a treatment option. Next slide. Quickly touching on asthma, and I know that Tom is going to go in much more detail. In my head, because I can't remember complex things, I usually just remember if they're more than 3, if they've had more than 3 episodes of wheeze, and that's the diagnosis of asthma. And that's what I got taught a long time ago in medical school, and it's a lot more tricky than that now. You need to find out, have the children got interval symptoms? Have they got cough or wheeze between acute flare-ups? You will diagnose them as either episodic, which is you'll have an acute flare, then you'll get better, and then they'll have another one with their next cold, or allergen exposure. Those can be either frequent or infrequent episodes, or the children that have persistent asthma with persistent symptoms, be that mild, moderate, and severe. And you know, Tom's going to spend a bit more time talking about asthma, so I'll park it. Next slide, please. So preschooler wheeze now is going to fit into this age group of the 1 to 5-year-olds that get wheezy. It's really common, and we know that, you know, up to about 30% of children will have an episode of wheezing before they are 3. But though a lot of these kids, it all just goes away before they hit the school age. It is often associated with an illness, and it really is related to the caliber of their airway size. Next slide, please. It's important to think about the group within that will go on to have asthma. And there are some important risk factors that have now started to come out as we're teasing these groups apart. The child that has onset of wheeze before the age, that starts after the age of 18 months actually has a higher risk of going on to asthma. The atopic kids, the kids that have eczema, they have rashes to all sorts of stuff, they get to see Leith, they need to go and see James about their atopy. And if there's a maternal history of asthma, so these are the ones that have got evidence behind them, but certainly I also get a few kids that have a paternal history of asthma as well, and I think that's also a bit predictive, but I can't officially say that. Next slide, please. It's important to take a wheeze history, and I guess the phrasing of this has changed to now become a wheeze history rather than an asthma history. Has this child been wheezy before? What is their usual management? We still call them asthma action plans rather than wheeze action plans. And this is something that I think we need to look to adapting, because we're sending these kids home from hospital saying, you don't have asthma, but here's an asthma management plan. Find out what the parents have already done. Find out what the details of their management. Did they use 2 puffs? Did they use a mask? Did they use a spacer? How old's their Ventolin? Have they actually already used it all up? We all know to find out about past wheezy episodes and the severity of those wheezy episodes. Did they need an admission to hospital, but also did they need steroids for that? Do they get any interval symptoms? those mainly being any nighttime cough or wheeze with exercise, or is it I can't say is the other word. Exercise will do the word. Or do they use their puffer during the day for any reason? Does the cold air bring on a bit of wheeze? Lots of different things can make it come on. And I just usually say, well, how many times when you're well do you use your puffer and spacer in a day or in a week or in a month? And that brings out what I need to know. What family history is there? Is there a history of atopy in the child? And are there smokers in the house? Because we do know that there's a correlation with smoking. Next slide, please. I want to know the history of this illness particularly. You know, these kids often have other viral things going on. So do they have fevers? Do they have any contacts of illness, COVID, or any other contacts? Do they go to daycare? Have they been overseas? No, they haven't been overseas, because no one's been overseas. What's their intake? What's their output like? Because that's actually, you know, intake or not managing to take in enough is one of the reasons they're needing to come up to hospital. Otherwise, you know, your standard past medical history, any medications, any herbal supplements, any herbal treatments. Have they been immunised, or have they had herbal immunisations? What allergies have they got? What family, social, development and schooling history, just to round it out. Next slide. And it is important to get a set of vital signs, and no matter where you are, these are really predictive, particularly heart rate and I mean, obviously a few things can influence that. Temperature can influence heart rate, but it's a really important little one to get there. Respirate's so important. SATs, if you've got a SATs probe, but almost everyone can get a SATs on a thumb or a big toe, even on an adult SATs probe, and a blood pressure if you can. Colour, perfusion, alertness and posture of the child's pretty important, and what work of breathing they're doing. Can they talk? How well can they talk? What's the air entry like? The quality, the symmetry of the air entry. Are they hydrated? Like I said, it's important to know, are they maintaining their intake? Next slide. And hopefully most of the children that you guys are seeing are the mild group. They're alert and talkative. They might have had a bit of Ventolin already, so they're a little bit more talkative and alert. They've not got any accessory muscle use anywhere, a little bit of increased rest rate, but their heart rate is normal. Their saturations are above 94, and they might have some variable wheeze. The next slide. The moderate group will be conscious and alert, but they'll have a bit of accessory muscle use. They will be a bit tachypneic and a bit tachycardic, but they can still talk in phrases. They have wheeze that you can hear everywhere, and they'll have an oxygen requirement. Next slide. Hopefully the severe group aren't presenting to your practices, but they will from time to time. Agitated, restless, distressed. They'll have accessory muscle use. They'll be tachypneic and tachycardic. They'll have this very long expiratory phase, and they might be producing a bit of PEEP by pursing their lips together. They might be talking, but they're probably not. They may be tripoding and sitting forward. They'll have a really quiet wheeze, and they will be hypoxic. And then the next slide is the life-threatening group, which, you know, these guys are exhausted. They have an altered level of consciousness. They look pale and revolting. Their heart rate's starting to come down. It's a thready pulse. They're not making words or cry. They really aren't moving air, and they have a silent chest, and they're very concerning. And these ones are hard to tell if they're asthma or not, but if they've got a strong asthma history, you got to get some Ventolin in if you can to these children, as well as oxygen. Next slide, please.
And Sarah, just a 5-minute warning for your 4-minute warning.
Well, we're wrapping up, which is good. So we're back to Jackson. Next slide. So he has a previous admission for bronchiolitis and reactive airways, uses Ventolin whenever he gets a cold. He does have eczema. His father had asthma that he grew out of. He was a full-term baby, otherwise well, with no medications. He's fully vaccinated. Next slide. And his rest rate's 30 and his heart rate's 110. His SATs are okay. He's pink sitting up. You don't have a small blood pressure cuff, but he's well perfused. He's speaking in words. He's got a bit of work with mild subcostal recession, and he's got good air entry with wheeze everywhere. Next slide, please. So you decide that he fits into the mild to moderate group. He can walk and talk and speak in phrases, and his SATs are fine, and he's just got a bit of respiratory distress. Next slide. So his treatment is Ventolin, and it's Ventolin as required. And in his age group, it's 6-puff virus spacer, and you should be using a mask. Very hard to use a spacer in the older groups and get that information. Prednisone is not routine in this group. The evidence is evolving. It is definitely recommended if there's frequent episodes. The moderate severe group, so we're still probably using it to the group in hospital, and the strong asthma phenotype. So in this boy, he probably would think about giving him some prednisone. Next slide. We give Flixitide. We do use it in this group. Virus spacer, Flixitide Junior, 1 puff twice a day would be your starter. If a regular use of bronchiolitis, so if you're use them more than 3 times per week, and if you're having a regular use of steroids, and in the statewide guidelines, it's more than 3 times per 6 months, which is pretty regular. Next slide. And you can also alternatively use Montelukast, which is Singulair. It is still recommended as an alternative to inhaled steroids, but do be aware, I'm sure you're aware of the behavioural changes, headaches and depression risk that you can have with it. And next and last slide. So in summary, preschooler wheeze does have a broad summary, so don't be fooled into thinking it's just simple wheeze. Think about the foreign bodies, broaden that differential out. Treat it with Ventolin, see how they respond. Probably don't use prednisone in your first line, and that the kids with the more risk are the ones with an onset of wheeze over the age of 18 months. The history of atopy and a history of maternal asthma. And that's where I'll leave it, and I'll be hanging online, and we'll have some chats at the end.
Thank you very much, Sarah. So if people do have questions, just put them through in the chat box, and we'll hand over to Dr. Tom Hurley, who many of you know as our used to be Director of Paediatrics, still paediatrician in the hospital. Thank you, Tom.
Thanks, Michelle. Can you hear me?
Yes. We can hear you, Tom. Do you want the next slide? Tom's been having some difficulty. Oh, there he is. Back. No, this is not. Tom, we can't hear you again.
Okay, maybe a second.
You're back. So while we're waiting for Tom, I'm just going to read out one of the questions, which hopefully James Scorer can come back to later on, which is a question asking about a minimum age of prescribing intranasal steroids for children in terms of being able to use the device properly, or the appropriate age to use it from. That's the question. I don't know if you're there, James, if you want to answer that now while we're waiting for Tom.
Can you hear me?
Yeah, sure.
Okay. Look, it's basically, you hit the nail on the head there. It's a question of what the child can cope with. A lot of children have difficulty using it. Many children find intranasal steroids, they sting, or they feel funny, or they taste bad and refuse to use it. The the product that seems to have the least stinging and has the least bad taste seems to be Avamis. But the bottom line is that you give it a try, and if they can tolerate it, that's fine. There's no lower age limit based on, you shouldn't give it lower than 6 months or 6 years or whatever. That goes the same with immunotherapy.
Hello.
Use
Tom's back.
Hello.
If
Can you hear me,
tolerate.
Michelle?
Yes,
Okay.
thanks, Tom. We just had James answering a question while we were waiting for you, and you're back. So
Lovely, thanks.
We'll come back to questions at the end again, as planned. Thanks.
My apologies. Yeah, thanks, guys. I'm sorry. I've had contact with issues with the phone. Can you hear me clearly?
Yes, thanks.
Can you hear me clearly? Yeah, okay. So look, Michelle, can you give me a 10-minute warning, please?
Yep, sure.
Lovely. Okay, next slide, thanks. So my session this evening is really just an update on asthma, because you guys are experts on asthma. You see much more than we do. We just see the top end of the asthma, and you guys look after 99% of it. And I've got to say that our asthma admissions are less and less over time. So I think our general practitioner colleagues are doing a wonderful job. The goals of tonight are a quick literature update with the most recent stuff that I could find, looking at asthma definition, asthma diagnosis, asthma factors associated with respiratory tract infections and atopy, prediction models, because we often have parents asking us, is this asthma and is my child heading down that pathway? And finally, the management of asthma. Next slide. So asthma by definition really hasn't changed, and this is the most recent one through the Global Initiative for Asthma, and it says that it's a heterogeneous disease characterised by chronic airway inflammation, defined by the symptoms of wheeze, shortness of breath, chest tightness, and cough. These symptoms vary over time and intensity, and also patients present with a variable expiratory flow limitation. Next slide. The asthma, in terms of asthma diagnosis, this study was done from the Spanish Immunological Journal, and it really looked at the world's definitions of asthma, and they did a systematic review of clinical guidelines worldwide. Next slide. And they asked some important questions. The first one was, is there a specific definition for asthma for children under 6 years? The second question was, can asthma be diagnosed at any age, even in infants in the first year of life? And if not, is there an age for which a diagnosis of asthma can be established for children under 6 years of age? Are pulmonary function tests necessary to diagnose under 6 years of age? And are there defined and objective criteria for the diagnosis of asthma under 6 years of age? Or does the diagnosis depend on the physician interpretation? And finally, is it accepted that you can actually grow out of asthma? Next slide. So the impression, next slide, please. Thank you. The next, I'll go back again, just back one slide, thank you. So to answer those questions, looking at the clinical guidelines worldwide, and this is across all continents, essentially the majority of guidelines accept that asthma can be diagnosed under the age of 6, and I think that's consistent with most of our practice. It's diagnosed based on recurrent wheeze, shortness of breath, cough, and response to management. Again, consistent with our practice here in Queensland. They say that it can be made without the use of pulmonary function and complementary techniques. And so it's important, however, to consider alternative diagnoses, of which Sara has alluded to in the previous talk. Interestingly, there's significant variance of opinion. The Japanese were quite certain that you could evolve and grow out of asthma. The European Respiratory Society said you couldn't. We do seem to think here in Australia that you can evolve out of an asthma diagnosis. Next slide, thanks. looking at asthma cause and association of early life viral respiratory tract infection and atopic and asthma in children. Wadwa et al. In the American Academy of Allergy published an article which was just recent, looking at the relationship between respiratory tract infection and atopy and the genesis of asthma under the two-hit hypothesis. And this is something which I know we've heard a lot of, and I think, again, recent evidence suggests that things haven't particularly changed. Next slide, please. They did a systematic review again and a meta-analysis of all relevant articles looking at triggers of viral illness and atopy, and they were very specific in their criteria, which we don't have time to go in for. Next slide. But essentially, looking at this particular graph, I am looking at, let's just see, yeah, can you go to the next slide? Thanks, guys. Thank you. You'll see here that this is a graph looking at asthma and wheezing outcome in children. And the first part of the graph looks at non-atopic children and then gives a series of studies. And then the subtotal and summary suggests that your odds ratio is actually increased significantly by a factor of 2.32, which is statistically significant, in non-atopic individuals who get an early life respiratory tract infection. In atopic individuals, that risk is heightened to an odds ratio of 4.02. Again, consistent with our understanding that data and information. Next slide. This is just the digital representation of that, and you can see that actually a stronger effect. Atopy has a stronger effect the younger you are. So looking at the sub-children in preschool groups, the odds ratio, if you're atopic, goes to 7, a factor of 7, with a significant confidence interval there of 4.6 to 11. Versus non-atopic individuals who get an early respiratory tract infection, whose odds ratio is still increased significantly at a factor of 3.2. So respiratory tract infection has a very significant role to play, but more so in atopic individuals. Next slide. The next study was looking at allergic rhinitis and asthma, assessment of risk in paediatric patients, and again another systematic review published only recently again. This was looking at 25 years of data, push papers only, looking at the understanding between the multimorbidity of asthma, allergic rhinitis, and eczema, with the goal of this paper to try and better identify the risk factors in children with both allergic rhinitis and asthma, to try and understand what is most clinically relevant. Next slide. It was again a very much a broad view across 43 countries, again of well-constructed case control studies and cross-sectional studies. Next slide. They acknowledged that, as you've listened or you've heard in James's talk, that that it's a very common intersection between allergic rhinitis and asthma, with around a 30% crossover of patients with rhinitis developing asthma, and in fact 80% of patients with perennial asthma or persistent asthma having rhinitis. Next slide. They looked across all of these studies and found a positive association in a list there, which I'm not going to go into in detail, but it's worth having a glance in your handout in terms of clearly positive associations associated with allergic rhinitis and asthma, and you'll see that down that list there they'll note which one it is, whether it's asthma or allergic rhinitis. There's also negative associations as well, and then there's also ones with no statistical association. And I suppose there'll be some surprises in there, but it's good just to go through it and just familiarise yourself with potential factors that are increasing the risk of allergic rhinitis and asthma. Next slide. The next paper was on allergen management, and that was published in 2018 in Clinical Immunology. And this was really looking at, can we actually manage to reduce allergens to have a positive effect on quality of life allergic rhinitis, and asthma. And they looked at multiple interventions, including using pesticides, things that would kill dust mite, air purification, carpet removal, a high efficiency air filtration vacuums like your Dysons, mattress covers that we always talk to our patients about, mold removal, pest control, and pet removal, like killing the cat. No interventions, interestingly, as were associated with improvement of validated asthma control measures or pulmonary physiology. Interesting to note. But in terms of allergen management, it looked as though exacerbations diminished when you looked at multi-component studies reducing several risk factors, including that that high performance vacuum cleaners and pest control, and that showed a moderate strength of evidence that, in fact, if you give your patients advice with using those tools, then there is moderate strength evidence that that's going to make impact on their allergens and allergen response. Quality of life, there's a low level of evidence that air purifiers give any benefit, and a moderate strength of evidence that, in fact, again, these high performance vacuum cleaners can actually assist in decreasing allergen load. Single interventions were generally not associated with improvement in any particular measures, and so their conclusions in general, looking at across all these studies, was that further studies required.
Tom,
My take from that,
10 minutes. 10 minutes, Tom.
Thanks, Michelle. My take on that is that really, you can make a lot of interventions, and that can actually cost parents quite a lot of money. And I think that low-cost interventions, including things like your dust mite covers and removing, obviously, toys, soft toys, particularly that hold a lot of dust mite, could be quite useful as it's held up to the child's face. But a lot of these single interventions otherwise don't create a very significant difference. And in fact, your best management is looking at medical control of symptoms. So can you go to the next slide, please? Thank you. Okay, and I'll just get you to go through the next slide again. Lovely. Okay, just a brief mention. Acute respiratory tract infection and complementary medicines. While it's not exactly asthma, it was just an article that flew across my desk, and it was something which you will see again a lot of. And this is a study looking at how common complementary medications are used, and I suppose it was, for me, quite eye-opening. Can you have the next slide? The use in Australia for complementary medicines is high. And so around in Australia, the evidence suggests that 1 in 2 adults use complementary medicines and 1 in 3 children use complementary medications. And of course, the respiratory tract infections are the leading reason why parents take their children to see you in clinical practice per annum. Can I have the next slide, please? So basically, this study, Barron and Jordan, looked at complementary medicines used in Australia, and they looked at homeopathics. That was the bulk of the complementary medicines used, and they made the interesting point that it's something which probably is underappreciated by the medical community, and I'd be interested to get your points on that, your thoughts on that. I haven't yet seen complications from complementary therapy, but it may indeed stop the use of actual therapy, which is creating a positive outcome for the child. And it was just an encouragement to inquire, because they could well be slowing or diverting the parents from giving appropriate therapy. Next slide. So asthma prediction models, always a question from parents. Does this recurrent wheeze suggest that my son or daughter are moving into asthma? This systematic review published in Lancet Respiratory Medicine 2015 really looked at prediction models worldwide, and now looking really to see, can a group of symptoms or can a group of indicators in children under the age of 4 define whether or not they'll be more risk at developing asthma and present between the ages of 6 to 12. And so they looked at basic models, and the basic models were essentially looking at family history, the presence of allergy disease, the presence of comorbidities, precursors of asthma, and severity of early symptoms. Next slide, thank you. In summary, briefly, there was also models that looked at levels of IgE and other codeterminants. In essence, it's very hard to predict if asthma is going to be the outcome for your child presenting with recurring lower respiratory wheezy illnesses, and that was the outcome of this analysis. They are suggesting that, in fact, it should still be further refined, and they're looking at other biomarkers and other particular physiological markers, including expired nitric oxide, but at this stage it's still very much in development, and really we are no further down the track than we were 10 years ago. Next slide. Asthma management is where it's at a general practice, and I suppose the main reference that I've referred to is the Australian Asthma Handbook, of which the most recent version has just been published. Next slide. In essence, and I'm just going to run through this quickly because this will be confirming, no doubt, practice that you already do. But essentially, as we've talked about, boys under 12 months shouldn't be considered asthma. It's likely to be infection or anatomical, and you've got to think about those alternate diagnoses. We already know that Ventolin and steroids and oral steroids are really not effective in this group and really shouldn't be given unless they're exceptional cases. In that case, usually you've got the respiratory physicians involved. Next slide. We know that as children get older, they get more Ventolin receptors, they become more receptive to Ventolin administration. And really, it's only a very small group of these kids that actually progress to using inhalers. Next slide. This is a slide of looking after children over 6, but essentially over 6 years, it's often becoming a lot clearer that they do have a reversible airway obstruction, which is Ventolin responsive, and therefore short-acting beta agonists are indicated in this group of individuals. And preventers may indeed have a role, which we'll talk about in greater detail. And of course, they talk about the use of the asthma management plan, which you guys do regularly. The principles of asthma management is aiming for good control, trying to identify the triggers of asthma. Can you please go to the next slide? Thanks. Managing comorbidities such as allergic rhinitis, and indeed showing parents and children how and when to use short-acting beta agonists, and then having selection around who you progress to preventive therapy. Next slide. This slide of asthma control, I think, is one that reflects good control, partial control, or poor control. My take on this is that they say that partial control is when you've got daytime symptoms greater than 2 days of the week, and typically only briefly present and reacting nicely to short-acting activities. Any limitation of activities which suggest partial control, and any symptoms which make the child wake up or get disturbed at night time, or the use of short-acting beta agonists suggest partial control, and therefore considerations by ourselves as clinicians to potentially increase the level of control. Poor control is when you've got daytime symptoms which are quite significant and prolonged, partially or fully relieved by short-acting beta agonists, and in fact you're seeing these symptoms regularly through the week. Next slide, and the next slide again. So therefore, the principles of asthma management is really teaching a lot of education around asthma, and we know that's always a key. Obviously, trying to manage triggers, which we've talked about, including smoking exposure. Training in correct inhaler technique, information and support to maximise adherence. And again, I think we'll probably come in discussion with the use to complementary medicines as well. And of course, the opportunity to broadly discuss the child's health. Next slide. We know that inhalers in preschool kids are indicated, and nebulizers really don't have much of a role to play anymore. We know that dry powder inhalers don't work in this age group because they don't generate the airflow that's required. Next slide. This stepped approach is something which you can refer to later, but clearly it shows stages 1 at the bottom of the pyramid heading up to stage 3, and it's really all about the graded use of Ventolin progressing to the use of preventers, which you can do at your leisure. Next slide. And so this indicates the short-acting beta-agonist indications, which I'm sure will be clear to you, and we won't go any further into that, but it's a reference point. Next slide. Yeah, next slide again, thank you. This is all just relatively stuff that you know well. Next slide. So therefore, preventer indications, I think that there's probably something which is important to consider in the sense of if you have a patient whose symptoms are occurring at least once weekly or frequently disrupt their activity, whether it be play or sleep, please consider preventers. If they have flare-ups where they're visiting ED, okay, or they're requiring oral steroids under your supervision, then consider prophylaxis or preventer. And finally, flare-ups which are significant enough to require PICU is a given in terms of getting preventers started. Next slide. This just gives you a nice, again, just a graphical distribution, a demonstration of severity. It's worth having a look at and looking at the indications of whether preventers should be started. And essentially, any moderate flare-ups that are occurring 6 months or less, consider preventers. Okay, and anything which is severe, preventers are indicated. Next slide. Okay, and so we've talked about that already. We'll move on to the next slide. Montelukast is a friend which you can utilise, particularly in kids with exercise-induced, young kids in exercise-induced asthma and kids with significant allergic rhinitis. However, it does have some drawbacks. Next slide. You guys will be familiar with the concerns around Montelukast, and which has been mentioned by the previous speakers. The corticosteroids are our go-to, and we've already mentioned the indications. Next slide. Next slide again. So I think we've probably reached the end of our talk. This is just a list of inhaled steroids, low dose versus high dose. Again, as you guys are very well aware, we're trying to maintain children's symptoms under management under the high dose threshold, and there's a range of medications which no doubt you'll be choosing to use. Next slide. And I think that's it. Thank you.
Great. Thank you very much, Tom. There are actually 3 questions here. Now, this session is due to finish at 8:10, so we've got enough time, I think, to answer the 3 questions that have come through that are all here for Tom. So I'll just run through them quickly. The first one, is Intel still recommended at all?
Yeah, Intel. Yeah, the question is that Intel really is an add-on, and it's really used only in children where you have got maximal use of inhaled corticosteroids. You're often using your long-acting beta-agonists, and you still need some additional symptom control. That may be indicated as a 3rd line, but otherwise it really now, in terms of the 1st or 2nd line, is not utilised.
Great. Second question, could smoke inhalation from a fire alone trigger asthma in children who are atopic and have no family history?
Yeah, smoke can certainly.
Yeah.
Yeah, smoke, whether whether you're atopic or non-atopic, can induce bronchospasm. And of course, it depends on what chemicals are in that smoke. But yes, it certainly can, and that can be a potential trigger, particularly in our bushfire season.
And the last one, the Australian Asthma Handbook has been updated recently with first-line treatment for adults suggested as budesonide-formoterol combination. Would you also recommend this for kids aged 12 and above instead of PRN Ventolin first line?
Yeah, look. I think there's certainly a trend to that, and this is looking at our kind of early teenage kids, and that seems to work extremely well. It's great it's better for compliance, and it's yes. And so the answer is yes, very useful.
Good. Okay. So I don't know if there's any other questions at the moment. If people could send them through very quickly, we can then cover them. That's all we have for questions at the minute. And while we're waiting to see if anything comes up in the last few minutes, I wonder if we could go to any of the panelists who have something that they feel that they need to or they'd like to say in response to any of the questions so far, or anything they've just thought of they'd like to get across a message to the GPs in the area. Just unmute yourself and speak up.
I could speak to that. Look, I think that in general, just from the asthma point of view, I think in general our general practitioner colleagues are doing a really good job, and so this kind of the benefit of this tonight is really just more of a refresher on any other recent changes in this space. So I think in general there must be a very significant, a good level of care out there to manage this significant group of kids.
Great. James, did you have anything? Yeah, sorry, that is James.
Yeah, Montelukast has had a bit of a bad rap today. And, you know, it came out in the newspapers that these kids became psychotic and that they were behavioural problems and so on. The vast majority of kids who use Montelukast are fine. It's interesting to note that the Australian Paediatric Surveillance Unit has got a shout out to see what type of symptoms, these behavioural symptoms that Montelukast produces. So hopefully in time, we'll hear how common they really are. My experience is that I think in the last sort of 15 years, I've seen one child who's had behavioural problems, and I've prescribed a lot of Singulair. So I don't think it's as bad as it's made out to be. Great,
thanks. There's, sorry, one more question that's come through, probably aimed at Leith, but someone else may have to answer. Is Elidel a better option if there is perioral dermatitis reaction in steroid use?
Yes. I often use Elidel around the eyes and on the face, rather than using any of the stronger steroids, and certainly Elicon shouldn't be put anywhere near a face. But yeah, Elidel is a very useful sort of for faces, as it were.
Okay. All right. Any final comments? I think we've come to the end of the questions and amazingly managed to get through our talks. Thank you for doing so well, presenters. You've managed to condense a lot of information into a very short period of time. Any final comments?
Yes, it's Sara here. Hi, I agree with you, James. I've had really huge amounts of success with Singulair, and I'm not afraid to use it. I certainly think it does a really good job, but I do talk to my families about it. I have had some children with side effects on it, but nothing terrible. And the other thing is, Tom was mentioning about homeopathic or herbal supplements and remedies. I've had a few, perhaps because I do a lot of Gympie clinics, and there is that group around the Pomona Kuran area that do dabble more in natural things. And I have had a child or two with some side effects from the homeopathic medicine. So it's always something I ask about specifically, because I think if you don't ask the question, you don't know what you're going to find. I would also say that I think in the preschool or Wheeze group, we'll get rid of using steroids completely in the next 10 years. For the group that are the more the straightforward preschooler wheezes, no atopic history, no other asthma sort of risk.
Can I just hold with that? You just to clarify that you're suggesting oral steroids. Is that what you mean for preschool wheeze?
Oral steroids.
You're not talking about inhaled steroids.
No. Well, but then in that group that have recurrent preschooler wheeze, the atopic history, they're the ones who you're contemplating. Are they actually going to be the ones that end up having asthma long term?
Or asthma.
Severe illness.
So I think it's important to emphasise the fact that these group of children don't particularly respond or aren't particularly getting benefit from oral steroid courses. Is that what you mean?
That's what I was meaning, absolutely. And looking at the trends and the evidence thus far, I think it's going to be a bit like bronchiolitis. We don't use steroids in bronchiolitis anymore, and none of us even think about it. And I think that the bog standard preschool wheeze is going to go that way too.
Great. Thank you, everybody. We're out of time.
From James, for God's sake, look up the children's noses. You'll find things.
Thank you. Now the webinar is recorded. There will be evaluation forms that come out after the webinar. Please fill those out. And if you think of any burning questions after this, you can always send them through to the GP liaison unit and we'll forward them on to the presenters. Thank you.
Thank you.
Thanks, guys.